Hi, I'm Dr. Patrick Fink. I'm an emergency medicine physician, wilderness medicine fellowship trained, and I work with ski patrol and search and rescue. And I'm here today to bring you some critical airway skills for use in the pre-hospital environment. I'm going to talk about how to use a pocket mask, oral airways, nasal airways, a bag valve mask, and how to insert and use an oral laryngeal mask airway, also called an iGel in our practice. All of these skills are critical for pre-hospital care. They are initial life-saving measures for someone who has absent or insufficient respirations. So these are critical skills you have to be able to march through in an algorithmic way without thinking about it in the moment, so that when you're in a stress situation, you're not reinventing the wheel. Let's jump in. Our two main tools that we have to manage the airway in the pre-hospital setting are oral airways and nasal airways. Those go in exactly the parts of the body that you would think. Both of those give us access to the posterior oropharynx, a way to deliver air to the back of the throat, even when we encounter the enemy of the airway. The tongue. Let's look at the anatomy of the tongue and how the tongue is the enemy of our airway management. The tongue takes up a huge amount of space in the mouth and obstructs potentially the trachea. This structure here is called the epiglottis. The epiglottis covers the vocal cords when you swallow so that you don't aspirate food. Our goal is to deliver oxygen to this orifice, to the trachea, and not back here to the esophagus. Our oral airways, when inserted into the mouth, will sit behind the tongue and serve two purposes. The first is that they essentially hook and pull on the tongue and prevent it from moving backwards and obstructing the airway. The other advantage is that they contain an air passage directly through and can act as a straw, delivering air straight back to that tracheal opening. Nasal airways, in contrast, when inserted through the nasopharynx, will insert posterior to the tongue and provide a route of airway delivery that skips the mouth entirely. Finally, our other common airway tool that we might use in the pre-hospital environment is a laryngeal mask airway. There are many different varieties. This is the iGel airway, which doesn't have any inflatable components. This, when inserted past the tongue, slots down and makes a nice tight seal over that tracheal opening. You can see the trachea there with the epiglottis, and this orifice comes down, slides posterior to the tongue, and snugs in right over that opening, helping to deliver air directly to the trachea and also blocking off the esophagus. Meet Jerry. Jerry's going to help us learn about airway management today. The beginning of airway management starts with the most common tool that you might have, and that's the pocket mask. This is an essential thing for any BLS provider in the pre-hospital environment. The reason for this is it's essentially the only safe way to deliver ventilations while you're alone, unless you happen to have a bag valve mask. The most common components are this inflatable rim, and then I hope, for your sake, that yours also has this valve. This valve is important because it's a one-way valve. Why do you want a one-way valve, you ask? That's to keep the patient from vomiting in your mouth. If you look at the structure of the mask, you'll see that there's a narrow portion at the top and a wider part at the bottom. That narrow part goes up over the nose, the wider part goes down over the mouth. Now, the most important tip that I can give you when I talk about using this mask is that when we put it on the patient's face, we need to pull the patient's face up into the mask and not push the mask down onto the face. You probably learned in your CPR class that there are two ways to open the airway. In the classic CPR model, there's the head tilt chin lift. This is great if someone has a cardiac arrest on a sofa. However, for most of our pre-hospital patients, we're going to have a patient who is potentially subject to trauma. So in those patients, we want to use a jaw thrust maneuver to open the mouth. A jaw thrust begins with putting our thumbs on the bony prominences right below that patient's eyes, and then reaching back for the corners of the mouth, right behind the jaw. And then I'm going to push into the patient's face and pull forward to drive that jaw forward. As soon as I introduce the mask, I want to do the same thing. So instead of pushing down onto the patient's face, which is going to cause obstruction, I'm instead going to put my thumbs on both sides of this mask, reach behind the angle of the jaw, and essentially jaw thrust and pull that patient's face up into the mask. I can then give breaths by blowing into that mask. The strap is handy if you're a solo rescuer. You can leave it around the patient's face to help keep things secure while you go off and do your chest compressions. If we're struggling to deliver air to Jerry because Jerry's airway is obstructing, he's snoring and his tongue is falling back in his throat, we then have two strategies that we can use to help deliver air past that tongue. The first main strategy is the oral airway. The oral airway, as we discussed, is essentially a tube that's going to help pull the patient's tongue out of the way. They come in a variety of sizes, they're cheap, they're durable, and they're basically irreplaceable. Now, for adults, you can basically get rid of most of the smaller sizes, and I frankly find that in most sets, the red one is the right size for the patient. But if we want to be precise, how do we measure them? Let's return to Jerry. Our goal is to pick an airway that goes from the corner of the mouth to the tragus of the ear. That's the little, you sometimes get a little piercing on that guy. So we can check by placing the airway at the corner of the mouth and trying to measure it back towards the ear. This one looks a little bit small for Jerry. Let's try the red one. Corner of the mouth to tragus of the ear. Perfect. Now, how do you insert an oral airway? First, make sure you have proper personal protective equipment. In a patient who has a relaxed mouth, my favorite approach is just to hook the tongue, make some space, and slide the oral airway along the curvature of the tongue. Not everyone makes your life that easy, however. Sometimes folks have a little bit more of a clenched down airway. If that happens, sometimes you need to work it in towards the corner of the mouth, get behind the tongue, and sneak it in there. If someone has a really clenched airway, it may be necessary to use a second oral airway as a sort of bite block, as a lever. And so we're going to try to slide that into the corner of the mouth. We can actually use that to kind of rotate in halfway, make some space in the jaw, and now we're going to slide in again. In people who have a truly enormous tongue, again, retracting with a finger can be helpful, but sometimes we might place that airway in upside down so we can hook in behind the tongue, and then we'll rotate and drop it into position. Now that that airway is in place, we can use our mask over it, and again, fingers below the eyes, hands behind the jaw, we're going to pull forward, and then we can deliver our breaths. But you may encounter a situation where you just can't get the patient's mouth open, or perhaps there's substantial trauma within the mouth, so you don't want to use that orifice. That's when we move to the other orifice, to the nose. Nasal airways similarly come in a variety of sizes. The two best ways to size this are similar to how we do this with the oral airway. If you want to be precise, you're going to go from the center of the nose, again, where we're going to throw that piercing, out to the tragus of the ear, piercing to piercing. They tend to be all kind of roughly the same size, so frankly what I do is I look at the patient's nostrils. And I say, hey, what's the biggest tube that I can get in there? When we look down into the patient's nostril on either side, we'll generally see one that is more patent than the other, or more open. Whichever nostril looks bigger, that's the one we're going to use. These things you want to lubricate. Use surgical lubricant, little packets, to lubricate the whole nasal airway so that it slides in easily. I'm using mannequin lubricant here so we don't ruin our dummy. So I'll lubricate that, and then we're going to have the curvature towards the back of the patient's throat, right? Because we're trying to deliver air down into the airway. I pick the nose that looks the best, and I start feeding that thing in along the floor of the mouth. My trajectory is aligned here with my finger. I'm not pointing up this way. As I feed, if I encounter resistance, I'm going to stop, and I'm going to try the other side, and I'll advance my airway. You can hub that thing. Put it all the way in there. If the patient has 2 patent nostrils, there's no reason that you can't fire a second airway in there. We don't want to use the nasal airway in people who have substantial head trauma in and around the nose or the back of the throat. The reason for that is this goes right up under the cribiform plate of the skull. So if they have substantial fractures at the skull base, you can go boop and make a brain biopsy. And our goal is not to put the airway into the brain. Our goal is to deliver air back to the trachea. Can you use both of these things together? You sure can. In a patient who tolerates both, doesn't gag, allows you to place these in there, those 2 airways are going to create a pathway for air into the back of the throat. And again, mask goes over both of them, thumbs near the top, pulling up. In some patients, you may still have difficulty ventilating, or you may want something a little bit more secure than using a mask, which has to come on and off. In those patients, or those who are actively vomiting, we might choose to use the laryngeal mask airway, or LMA. The type that we use in our practice is the iGel LMA because it's very simple, and I'm going to show you that now. The iGel LMA comes in a variety of sizes, and they're color-coded. I have here a 5 and a 3. The most common size you're going to use is a 4 for an adult patient, and that one has green plastic. The reason I don't have that here is because we use them all the time, and so these are our overstock. We're going to use a 5 on Jerry, which is orange, because this thing's open and I found that it gets a good seal on him. Now, ours come in the slightly more deluxe package, which has the airway securement built in there. So when you take this thing out, it comes in this little tray. Don't throw the tray away. It's useful. If I'm going to place an iGel, I'm going to be replacing this oral airway. The nasal airways can stay or they can come out, but they're not going to be useful to us anymore once we use this. To prepare the iGel for use, we're going to take it out of the plastic tray, and we want to lubricate this part fairly thoroughly. Again, you're going to use your surgical lubricant. I'm going to use my mannequin lubricant. There's no such thing as too much lube for an iGel. Just try not to get it up near the top here, because then it's going to be slippery if you try to handle it. It's helpful to place it back in here to keep it all nice and clean and tidy until you're ready to use it. When you anticipate using it here on Jerry, it's helpful to unwrap this nice retaining strap that comes with it. And I'm just going to feed that right behind Jerry's head with a roughly equal number of holes on either side. Now I'm going to remove my oral airway. And since I know I'm not going to need it, I'm going to pull my nasal airways out as well. Now I'm going to take my iGel, and again, my favorite tactic here really is just to hook the patient's tongue and slide this thing in here. If you need, you can also again come in backwards and then rotate, but that takes more force. Now rotation move. The important part is to try to hook the tongue in some way so that this has a clear pathway into the back of the mouth. You'll feel it really snug in, and again, just gentle but firm pressure to settle that. I will secure it by bringing up one set of holes on one side, pulling this up on the other side. You can take the valve off your mask and stick it on there and ventilate the patient all by yourself. But here's where we get into the use of the bag valve mask. This is a bag valve mask. It has all of the typical components. This is a pocket bag valve mask, so it's a little bit smaller than what you may use in your practice. It's got 3 parts. It has a mask, it has a bag, and it has a little reservoir. You can hook oxygen up to whatever the oxygen port is, and it will or it won't inflate the bag. But the important part is that there's some valve work at the back, so when you squeeze it, air comes out, and when it refills, it's filling through that oxygen reservoir. One thing to be aware of is that your pocket mask probably is not compatible with the bag valve mask. These tend to have different diameters. Why? I don't know. It seems silly. But if you have your pocket mask on the patient, you're going to need to remove that when you move on to the bag valve mask. This mask can be positioned in any number of positions depending on where you're working. Let's take the bag to Jerry. One of the advantages of using a laryngeal mask airway is that they tend to be a very secure platform for bagging a patient, and it keeps this end of the business very simple for you. If you're using a bag valve mask, you're going to remove the mask portion. That easily goes straight on to that laryngeal mask airway. When you bag the patient, we're just going to give a gentle squeeze. Our goal is not to flatten the whole bag, but a gentle squeeze is going to inflate the patient's lungs just fine. Excessive ventilation is going to go into the patient's stomach, which we don't want. Ventilating with just a bag valve mask alone and no LMA is a significantly more complicated motor task. Generally speaking, you're going to want to have airway adjuncts like your oral airway and or nasal airway in place. These will make it easier to get past the enemy of the airway, the tongue. The difficult part about performing bag valve mask ventilation by yourself is the need to obtain a good mask seal while also squeezing the bag. This is challenging because, as we discussed before, you really need to pull the patient's mouth up into the bag rather than smush the bag down onto the patient's mouth. This closes off the airway. The grip necessary to ventilate by yourself is called the C-E grip. See the C? See the E. The C hooks around the patient's mask, and then the E is going to grab behind the jaw. We're going to pull up rather than pushing down into the face. This is a very complicated motor task. This was developed in the operating room for anesthesiologists to induce patients into anesthesia all by themselves. You can then use your other hand to bag the patient. However, if there's a bag valve mask on scene, there's probably two of you. So the best strategy is to have one person performing that two-hand mask grip, like I demonstrated previously, thumbs over the patient, just below the patient's eyes, gripping behind the jaw and pulling up, and then your friend can squeeze the bag for you. Now let's put this all together to save apneic Jerry. I arrive and evaluate an unresponsive patient. Hey Jerry, can you hear me? Hey, Jerry's not breathing for himself. I need to help Jerry breathe. I recognize that Jerry has potentially some trauma, so the first thing I'm going to do is open Jerry's airway by performing a jaw thrust. Fingers under the eyes, hands behind the jaw, push that jaw forward. Shoot, Jerry is still not breathing. I need to give Jerry some breaths. I'm going to get out my pocket mask and put the skinny part towards the nose. I'm going to put that over Jerry's nose and mouth. Same two-fingered, two-hand grip. Pull up. I'm able to give Jerry some breaths, but he's still not breathing on his own, and frankly, it's hard to get air in there because his tongue is obstructing. So the first tool I'm going to reach for, after checking Jerry's mouth for any obstruction, removing any snow or foreign objects, is I'm going to reach for my oral airways. These are just in my pocket. I'm going to quickly lubricate that if necessary, and I'm going to slide that right in there, hook his tongue into the back. It's going to rest right up against the teeth. Looks great. Mask goes back over the top. Two-hand grip. If I need any additional airway, I'm going to put that nasal airway in there. And if I have the time, I'm just going to hub him full of airways. If he tolerates this well, fantastic. I now have my BLS partner who's arrived and brought the bag valve mask. So I'm going to get rid of my own mask, which isn't compatible. And we're going to put this over Jerry's mouth. If we're by ourselves, we're going to use that CE grip. 2 fingers on the mask, 3 behind the jaw. Pull Jerry's mouth up and ventilate. But that's a complicated task, so I'm going to ask my other friend at the top of the head to give me a 2-hand grip. 2 thumbs over the mask, pulling up on the jaw, creating good jaw thrust, and then I can bag. However, now we need to move Jerry, because we got to get Jerry down to the ambulance. So I want a more secure airway. We're going to prepare our iGel airway while continuing to bag him. When we're ready, we're going to prepare the iGel strap by sliding it back behind his head so it's ready for us. I'm in a hurry, so I'm not going to worry about those nasal airways. I've lubricated my LMA nicely. I'm going to remove the oral airway. I like to hook a finger and then slide and then snug that down and right in the back of the throat. I'm going to bring both sides of this up, hook one side, hook the other side. That's nice and secure. I'm going to take my bag off, put it on my LMA, and now I'm ready to bag. That's it for this review of basic airway skills. To march through the critical algorithm once more, when you arrive on a patient who is not breathing or is breathing insufficiently, the first thing I want you to do is assess that patient's level of alertness with a good sternal rub, check the mouth, the airway for any obstruction or foreign body, and if that patient is still unresponsive, instead of performing a head tilt chin lift, I want you to perform a jaw thrust. The reason for that is the potential for trauma. Just find that it's more effective. If that is insufficient to get the patient breathing again, then we're going to get out our pocket mask and provide that patient some breaths. Don't push the mask down into the patient, pull the patient up into the mask. If you're still not able to pass air easily, then it's time to place some airways. Oral airway is my go-to in a patient who will tolerate it. So, no alert patients, no patients who gag when you put it in, and no patients who have significant trauma in and around the mouth, because we don't want to break things and shove bones and loose teeth where they shouldn't go. But an obtunded patient who is unresponsive, has a clean airway, accepts that thing readily, solid gold for keeping the tongue off the back of the mouth and making ventilation a lot easier. Ditto for the nasal airway. These are great in patients who are breathing not quite enough. So opioid overdose, severe head injury, you can slide those nasal airways in, and it might even increase your patient's Glasgow coma score. If they tolerate it well, great. OPA and NPA. You don't want to put NPAs in people where you think they might have a skull fracture or where there's significant trauma in the midface, because again, we don't want it to go into the brain. We want to deliver air to the trachea. So oral airway, nasal airway, back to the pocket mask. As soon as your friend arrives and brings with them the bag valve mask, we're going to take that pocket mask, put it off to the side, and use the mask that came with the patient to administer breaths. 2-person technique is necessary in most settings. If you're by yourself for some reason, there's that CE grip, but this is something you shouldn't try first time on a real patient. It's a tough skill. So, 2-hand grip with one rescuer and then the other rescuer performing the respirations. When it's time to move that patient and you need a more secure airway that's going to stay in place for you, or if you have concerns about protecting that patient's airway from vomiting or other body fluids, that laryngeal mask airway that's going to cup the airway and protect the esophagus and trachea and keep the two separate is the way to go. That laryngeal mask airway, the size 4 in the iGel, the green plastic, is the right size for most adults. 5 if you have Andre the Giant, 3 for smaller women or adolescents, and then the sizes do go all the way down into the pediatric sizes. You secure that airway in the mouth, gently snugging it against the back of the throat, and then you can bag with the bag valve mask. Occasionally that laryngeal mask airway, the iGel, will try to back itself out as you maneuver the patient or as you do your bagging. If you're hearing air blowing out of the patient's mouth or every time you give a breath, snug that thing back down using gentle pressure, and that will usually give you a good seal. If you're not getting a good seal, you might need to go up a size on the laryngeal mask airway. So those are our critical tactics for initial BLS care, the iGel ALS care, but initial airway management of the pre-hospital patient. I hope this has been useful. Get out there, save some lives.